Welcome to the IACM Cannabis Talk with Dr. Franjo Grottenherman.
Welcome to the first Cannabis Talk of the IACM. I have the great pleasure and honor to welcome the chairwoman of the IACM. She is a physician in psychiatry and neurology and works as a senior physician at Hannover Medical School. Her specialty is Tourette's syndrome and other tic disorders. Well, I would like to know how you came to the topic of cannabis and cannabis, and when it was, and perhaps you can share a little bit of your first experiences.
Yes, so first of all, thank you very much for inviting me and being the first person who joins this cannabis talk of the IACM. So as you mentioned correctly, I'm a physician, and this means I'm treating patients. And for about 30 years now, I'm the head of the Tourette outpatient clinic at Hannover Medical School, and I see hundreds of patients suffering from tic disorders per year. And until now, Tourette syndrome is a clinical diagnosis. So in other words, you have to see, you have to investigate the patients, and you have to talk to the patients, and you have to listen to the patients, and have to learn a lot about their history. And one of the questions we always asked our patients is, what improves or what deteriorates your tics? Because tics are characterized by waxing and waning, by spontaneous fluctuations, but tics are also influenced by a lot of environmental factors. Many patients report that relaxation, concentration improved their tics, but on the other hand, stress deteriorates the tics. And while asking this, more and more patients reported, okay, doctor, when I use cannabis, then this really improves my tics. And because I've heard this again and again, I thought about this aspect and wondered whether this was only by chance, whether this was a kind of a placebo effect, or whether this might be a real pharmaceutical effect. And this is now more than 30 years ago. And at that time, and this is still true here in Germany, use of cannabis was illegal. I decided to ask my patients in a more structured way, using a survey, and I asked them about different legal and illegal drugs. So we asked about the use of nicotine, the use of alcohol, and the use of cannabis. And I asked the patients whether they had used it once a time in their life and what kind of effects they experienced after the use. And I was really astonished because a relatively large number of patients, and most of my patients are young men because Tourette's is more often in male compared to female, they reported that they have used cannabis. And I think more than 80 or even 90% of the patients reported that use of cannabis improves their tics. And some of them had used standardized medicinal treatment, and they were able to compare the effects of cannabis to standardized medication, and this is normally antipsychotics or neuroleptic drugs. And those people who were able to compare these different effects, they reported that in their feeling that cannabinoids are more effective compared to neuroleptic drugs. Mm-hmm. And after we have heard this, we decided to treat one single patient with pure THC. So at that time, it was not so easy to do so in Germany because there was no drug available. And we decided to import Marinol from the US. And we decided to do this case study in a patient who had used cannabis before and asked him to compare the effects of THC to smoked cannabis. And we were mainly interested in to see what happens when he uses THC in front of us. And indeed, his tics improved. We did some neuropsychological tests, and there were no detrimental effects. And therefore, we decided to move on and to perform a single-dose trial where we again used pure THC and compared in a crossover design in a small sample of only 12 patients, THC versus placebo. This was the very first controlled trial in Tourette patients. And because the results were positive, thereafter, we decided to move on. We did another trial, and only recently, and perhaps we will talk about this later on, we completed the first large controlled trial. So to summarize, the idea to use cannabis in patients suffering from Tourette's came from the patients because they reported about beneficial effects.
Yeah, that's what we often see, that patients report to their doctors, I make this experience with cannabis and it may be helpful in a large number of diseases. And to my knowledge, it's only glaucoma that was detected by scientists, that it may reduce intraocular pressure, and other indications were detected by patients indeed, yes?
Yeah. And this is in diseases such as Tourette's, it's not such surprising because we cannot cure this condition. And the treatments we can offer to our patients only can reduce tics. So today we use a specific kind of behavioral therapy. This is without any side effects, but tic reduction on average is only 30%. And on the other side, we use newer antipsychotic drugs. So on average, we say to our patients, tic reduction is about 50%, but a relatively large number of patients has to accept that these neuroleptic drugs are associated with side effects. And therefore, in this situation, and this is for many, many different conditions, our reality, for these conditions, patients, of course, search for new treatment options. And a lot of my patients report that they used cannabis recreationally together with friends, and by chance, they detected that it also improves their tics and comorbid psychiatric conditions.
So the first publication was a survey, yes?
Yes,
exactly. I don't know, 50, 60 patients or something like that? I don't remember correctly.
It was, I think it was something like 30 patients. So it was not that a large group, but this was indeed the very first beginning.
Very good.
Before we published this, 2 case reports had been published in the 18th and 19th from the US, and I think a case report from Australia. And in these 2 small case reports, 1 and 3 patients respectively were described, and it was more or less exactly the same. The authors reported about beneficial effects of otherwise treatment-resistant, severely affected patients with Tourette's, and they reported after using cannabis that they had an improvement, not only in their tics, but also in psychiatric symptoms.
And what do the patients tell you about side effects with regard to cannabis compared to standard medication? What do they prefer, or what is your experience in? I think you usually would also treat many patients still with standard medication, I think.
Exactly.
Yeah.
Exactly.
And what is the feedback you get from the patients when it comes to side effects and tolerability and efficacy?
So it's not the same in all patients. So I have indeed a small number of patients who stopped cannabis-based treatment because of side effects. but it's only a relatively small number of patients. As mentioned in the beginning, Tourette's is more often in male compared to female. And Tourette's is a neurodevelopmental disorder. So this means tics starts in childhood. They increase during adolescence, and they often decrease in early adulthood or in later adulthood. But we have a lot of patients who are young adults. And this is, of course, a group of patients who may suffer from less side effects compared to children or compared to elder patients. So in most of the patients, I would say cannabis-based medicine is well tolerated. And compared to neuroleptic drugs, most patients report that the cannabinoids are better tolerated than neuroleptic drugs. And this is definitely a problem with our standard medication. And this is well known and not different compared to other groups of patients. Neuroleptic drugs often have side effects like sedation, weight gain, increased appetite, sexual problems, and so on and so on. And you, in addition, have to check blood and ECG routinely, not to overlook any side effects.
Mm-hmm. And of course, we know that Tourette's syndrome is associated with tics, but there are also some other symptoms. Are these also influenced by cannabis, or perhaps you can tell us a little bit what Tourette's syndrome means for a patient, and which symptoms or feelings or something like that are influenced by mainly THC, I think. Yes, we are talking about THC-rich cannabis, not about CBD, yes?
Yes, exactly. So these are two different questions, and I would like to answer first the second question regarding THC. Yes, indeed. There's no single case study suggesting that CBD improves tics or psychiatric comorbidities. All studies we have report about beneficial effects using pure THC or cannabis extracts or cannabis flowers. And there's a very small study from Israel published only a few years ago, and they try to disentangle the effects of THC plus CBD, and pure CBD. It was a single-dose trial in a small number of patients, less than 10 patients. But what they found was that there was an improvement of tics and premonitory urges after use of THC and THC plus CBD, but there was no effect after pure CBD. And this is completely in line with all the literature and with all the clinical experience we have. So in other words, it seems that the most important compound is THC. And based on my clinical experience, I would say the combination of THC plus CBD, other cannabinoids, and perhaps also other ingredients of the cannabis plant might be more effective and better tolerated compared to a pure THC. But we do not have robust data on this. But without THC, I would say you cannot improve tics. And your first question regarding the clinical aspect. So Tourette syndrome is defined as a chronic combined motor and vocal tic disorders. Tics are involuntary movements or vocalizations, and most often they occur at the eyes, in the face, at the head. So typical motor tics are eye blinking, grimacing, head jerks, shoulder jerks, and so on. And typical vocal tics are sniveling, coughing, throat clearing, things like this. Of course, tics can be more severe and more complex, like complex jerks, arm movements, jumping, things like this. And vocal tics also can be complex, and the most well-known complex vocal tic is called coprolalia. Although this is not so common, this is something most people think about when talking about Tourette's. So in other words, some of these patients have an urge to shout obscene words. In 80 to 90% of our patients, we see in addition psychiatric comorbidities. So this is the very typical situation of our patients. And the most common psychiatric comorbidity in children is ADHD. And in adults, it's OCD, or in some cases, not the full-blown obsessive-compulsive disorder, but some obsessive-compulsive behavior. And other typical comorbidities include depression, anxiety disorders, sleeping problems. Also, addiction seems to be a problem. In some patients, we have some autistic traits or autistic disorders. We also have rage attacks, impulsivity. So it's really a relatively huge spectrum of different symptoms. And this is one of the most important things you have to keep in mind when you treat patients suffering from Tourette's, that you have to identify what is the most important symptom the patient suffers from. So suffering from Tourette does not mean you have to treat tics. It also can mean that you have to treat ADHD or OCD. Coming back to your question, yes, this is something we see in all our studies and case reports, that there is evidence that cannabinoids improve not only tics, but also some of these comorbidities. I have a relatively large number of patients suffering from comorbid ADHD, and most of them report that they have an improvement of ADHD symptoms as well. But I have other patients who report about an improvement in sleep quality, who report about an improvement in mood. So this is not different from other patient groups who also may report about improvements of these symptoms. But for Tourette patients, it's of course very important, because when you suffer from different symptoms, then normally you need more than one treatment for tics, one for ADHD, one for OCD, and so on and so on. And it's a benefit if you have only one medication that helps for all these different symptoms. Interestingly, in our large Canatics trial we completed only recently, we have first evidence suggesting that cannabinoids might be more effective in those patients who suffer in addition from ADHD, and might be more effective in male patients. So this is really an interesting finding. And of course, it needs more research to find out whether this is a robust result. But this is in line with my clinical experience, that when I think about what patients benefit most from cannabis-based treatment, then these are young men with comorbid ADHD. So this definitely needs further research and is definitely of interest.
Mm. And you talk about that you usually need maybe different medications to treat all the comorbidities. Are there, does it work usually to use, for example, ADHD medication together with neuroleptics, or are there conflicts, or this? If you use 5 medications, there may be interactions and so on. So that's what the Institute of Medicine of the USA said in 1999, that cannabis may be a treatment for several diseases in a single person. For example, AIDS patients may use it for appetite loss, nausea, sleeping problems, depression, everything. And that's what we often see as in the medical practice, that you can use cannabis to treat several symptoms. This is extraordinary.
Yeah, so this is exactly what we see, not in all patients. So I have some patients who use cannabinoids in combination with other drugs, but most of my patients indeed use only cannabis, no other medication, and most of the patients have exactly this aim. So they want to stop medication with methylphenidate for ADHD, they want to stop neuroleptics for tics, and they want to stop SSRI for the treatment of anxiety, depression, or OCD. And this does not work in all patients, but yes, definitely I have patients who can stop all these different medications, use only cannabinoids, and report about a significant improvement in their quality of life. And it's not only a reduction of symptoms, and this is most important, because we do not treat symptoms, so we treat patients. And the aim of our treatment is to improve patients' quality of life. And I've seen a lot of patients who report that they, after initiating cannabis-based treatment, they were able to go back to school, to reach exams, to go to university, to complete their job education. And so I'm absolutely convinced that there's a relatively large number of patients who really have a benefit with respect to their quality of life and their career as well.
And if you treat patients with cannabis, do they usually have experience already with cannabis, that they know cannabis works? And I go to the Dr. Kirsten Müller-Wahl, the very well-known doctor for Tourette syndrome in Germany, and just want to get it legal? Or do you have also many patients who don't even know that cannabis may work, and you suggest it to them? How is this relationship?
So I would say most of the patients who come to me still have some experience with cannabis. So they used it before, most of them illegally, and they've experienced this improvement and specifically come to my outpatient clinic asking for illegal cannabis-based treatment with cost coverage by the health insurance. But there are also patients who have never used cannabis before, who use different kind of treatments, but they didn't work that well, and they come to my office asking for cannabis. And in some of the patients, it's vice versa, so that I discuss with the patients what kind of different treatment options we have. And I suggest cannabis as second or third line treatment. Patients never heard about this. Not all of them, but some of them are open for this kind of treatment, and then they follow my suggestion to try this as another option to reduce their symptoms.
So the first line treatment is still neuroleptics, yes? And if this, or do you sometimes think I start with THC or cannabis or something like that? If a patient comes to you, and I think perhaps patients come to you who have already some experience with treatments. You are a specialist, and they may have also already tried some things. So how is the relationship? How do you decide? I use neuroleptics, I will use THC. What is the decision process?
So it definitely depends a little bit on different aspects. So it depends on patient age. It depends on medication they had received before. And it also depends on their own experience with cannabis. So the most typical situation is that patient had tried standard treatments, and according to our European guidelines, first choice treatment is behavioral therapy. This is specifically for tics called habit reversal training. Unfortunately, in Germany, we have the situation that there are not so many psychotherapists trained in this specific behavioral therapy. So in other words, it's not offered in many places, and most patients who want to try this kind of treatment do not have access to it. Second choice treatment is indeed neuroleptic drugs, and more specifically, it's a substance called aripiprazole. And when we discuss about cannabis-based treatment, we also have to keep in mind what is legal in Germany, what is allowed, what can I do as a physician. And in most patients, it's of relevance whether the health insurances may cover the costs. And we have a lot of experience now after 6 years legalization of medicinal cannabis in Germany. And so the normal process is you don't have to send an application to the health insurance when patients have not used these both kinds of treatment, or if there's no behavioral therapy for this specific TIC treatment available in their region, they have to document this, and they have to convince the health insurances that they have no chance to get this treatment. And second, patients have to demonstrate that they had used at least one of the most often used and recommended neuroleptic drugs, and only in these cases, health insurances allow or cover the costs for medicinal cannabis. They are relatively strict, unfortunately, up to today. And sometimes there are really very, very bizarre situations. So I'm really a Tourette expert. I did it for so many years. I saw thousands of patients, and then sometimes I receive back from the health insurance a recommendation for TIC treatment from someone who has never seen a Tourette patient. Some years ago, we received a recommendation first to use surgical therapy with deep brain stimulation. So it's sometimes it's really a little bit crazy.
You talked about clinical research. I know that you are still trying to make a largest trial. Perhaps you can tell us a little bit about the difficulties to conduct clinical trials, because everybody is saying we need more clinical trials to know more about cannabis and cannabis, how it works in different diseases. And but if I look around, there is much willingness to do clinical research, but it's not so easy, I think. You talked about the first trial with Marinol that had been imported. It was not legal in Germany, and perhaps you can tell us a little bit about the difficulties and how you manage with these difficulties, and yeah.
So indeed, it's really difficult. So because of different aspects. So first, large clinical trials are very precisely regulated in Germany and also in the EU. So you need a lot of knowledge, a lot of qualification, and a lot of people if you want to do a large, well-designed, randomized, double-blind, placebo-controlled trial according to national and international laws. So the situation changed dramatically with respect to all the requirements you have to have within the last 10, 15 years. So this is something you can only do when you work in a university clinic, at least here in Germany, and when you have support and have a team behind you who helps with all these regulatory aspects. This is the first point. then you have to decide between studies initiated by clinical investigators like me. So this is something we call investigator-initiated trials. We did this in the past with our Canatix trials. So in other words, I wrote the protocol and had the idea for this clinical trial, and the sponsorship. So all the all rights and also the whole regulation was at Hannover Medical School. So there was no pharmaceutical company involved, and no company organized this clinical trial. And besides these investigator-initiated trials, we have trials organized and sponsored by pharmaceutical companies. This is also important, but we know that all these trials are somehow influenced by the sponsors. Because when you are a pharmaceutical company, then you want to have a specific result, because you have economical reasons to do this kind of research. And this is something that is well known, and this is completely different compared to investigator-initiated trial. I'm interested in science, and it may happen that the study is negative. This is a pity, but this is also an important result to know, okay, this drug does not work in this indication. But the interests are completely different compared to independent clinical researchers compared to pharmaceutical industries. So this is the second aspect. And the third aspect is that because of all these different regulations we have to follow today, large randomized controlled trials are extremely expensive. So in other words, you need more than 1 million euros. So normally we calculate, when we design a large randomized controlled trial, between 2 to 4 million euros. It depends a little bit how many patients you will include, how many centers will be included. But for national, not for international trials, this is even more expensive. But for national trials, I would say today you need something between 2 and 4 million euros. And this is a lot of money. So you need someone who is able and willing to give this money to you. And there are, at least here in Germany, only 2 options. The money can come from a pharmaceutical company. And alternatively, we have some support from the government. There's a ministry here in Germany that is able to support and to fund this kind of trials, or the DFG, the German Research Society. But it's a lot of money, and therefore it's not so easy to get this money to do this kind of research. And these are the different aspects why we do not have enough studies in different clinical indications today.
So this may be also a reason why there is no so much research with cannabis flowers in for example, Tourette syndrome and other diseases, because if a pharmaceutical company which produces flowers invests 2 million euros into clinical research and it cannot be patented, and the other companies say, oh, well, very good done, we will profit also from this. This may also be a problem, yes?
Yeah, definitely. Patents are definitely very important, understandably, for pharmaceutical companies, and this is something that is not possible with cannabis plants, and this is definitely a major limitation with respect to research.
What do your colleagues think about, your psychiatrist colleagues at the Medical School of Hannover, about your work? Are they find it a little bit strange? Here's the cannabis doctor, or are you more respected today than 20 years ago, or what? Perhaps you can tell us a little bit how your surroundings or something react to. What is, or
So,
are there any experiences or anecdotes or something which you would like to share with us?
so I would say it's a mixture of skepticism. What I'm doing there, in particular in the very first beginning, this changed a little bit during the last years because more and more of my colleagues learned that cannabinoids may be effective, even in different psychiatric indications. But it needed some time to decide to use cannabinoids. In the beginning, they came to me, asked about how to do this. Some colleagues asked me whether I will treat these patients because they don't want to do it, because they did not really know how to do it. And now I think cannabis is more and more established. It's not that much established compared to standard medication, of course, but it's more and more accepted. And therefore, I have the feeling that most of my colleagues are interested in this. So
the colleagues at the Medical School of Hanover, or
yeah.
Okay.
And I think most of my colleagues know about this because there had been some reports in our MHH newsletters about my research and about cannabinoids. Sometimes colleagues ask me, I went down the floor and I smelled that there had been a patient who used cannabis because there's a specific odor, and this must be a patient who came to your clinic. This is something sometimes people tell me. Remarkably, only recently I had to send one of my patients who used cannabis, and he also used cannabis flowers, to our ward for psychotherapy. And I was very skeptical whether my colleagues would accept this during he was an inpatient in our hospital. And I said nothing, and I thought, okay, let it run and let's see what happens. And when the patient came back to me, he said, okay, it was no problem. They accepted my kind of medication when they heard I'm coming from you. And this was the very first time that I heard that even inhalation of cannabis flowers was accepted in our clinic. And this is, in my feeling, a kind of a breakthrough, because this is still a difficulty in hospitals in Germany, that in most cases it's not accepted when patients use cannabis in form of an inhalation. And I have a lot of patients who decided to switch from inhalation to oral intake while they were treated as inpatients. But we definitely have to find a way for these patients so that they don't have to stop their medication.
And you talked about other indications in psychiatry. What indications are you thinking about when you talk about possible therapeutic potential of cannabis? And what other, besides Tourette's? You mentioned already ADHD and obsessive compulsive disorder or sleeping problems. Are there other indications where cannabis may be interesting, or at least from case reports or experiences, or from your own experiences of patients, or from the literature?
So, in my opinion, the most interesting indication besides Tourette's, of course, is ADHD. So this is really remarkable how many people with ADHD use cannabis and report an improvement not only of hyperactivity, but also of impulsivity and concentration. So this is really remarkable. I see this in my Tourette patients, as mentioned in the beginning, but I see this also in patients suffering from pure ADHD. And although we have these reports from our patients, there's still up to now only one small controlled trial using nabiximols. And we all wait for new research specifically in this indication. And I'm still trying to get money for this. We submitted a grant application now 3 times to the German Ministry of Research and to the German Research Society, and we just decided a few days ago to try it another one. We decided to modify the protocol a little bit, but I'm still very much interested in this specific indication. So this is what I would like to investigate. But you are absolutely right. There are patients with pure depression who report about improvements. There are patients with PTSD. This is also an interesting indication.
Post-traumatic stress disorder, yes.
Exactly. Yeah. Although the database is mixed, there's some evidence that CBD might be effective in other reports. There are beneficial effects described after use of THC containing cannabinoids. So the literature is mixed and it's not really clear, but there are a lot of patients who report about beneficial effects. And there are some single case reports also in other indications like personality disorders. So this is of interest because in the very first beginning, and I remember very well when we wrote together our first publications, we wrote, don't prescribe cannabinoids in patients suffering from severe psychiatric or personality disorders. And this was based on the situation that we all had no clinical experience. But what we learned, and I think this is true for you as well, what we learned in recent years is that indeed cannabinoids may improve personality disorders. And in particular, I saw patients who had tremendous beneficial effects who suffer from a borderline personality disorder. So the database is very weak, and we of course need more robust data. But I saw some patients who really benefited from this kind of treatment, and this is the more important and the more interesting because we do not have good treatments for these patients besides psychotherapy.
I think for borderline personality disorder, there's only a small case series published and nothing else. Yes,
exactly.
Right.
Exactly.
But there seems to be a large potential for cannabis and cannabinoids in psychiatry. I think not only CBD. We know schizophrenia and CBD is an interesting topic, but also for THC. So there may be large potential, but many psychiatrists are very skeptical in general.
Yeah, exactly.
When it comes to cannabis, and they really oppose the use of cannabis for severe diseases. And what do you think? What is the reason? And perhaps we can also think, how can we change it? You mentioned already time. Time is an important factor. Yeah. And what is the current situation, for example, in Germany when it comes to psychiatrists and cannabis? Why is there such skepticism? Is it their education at the universities, or what is the reason for this skepticism? Is it the literature, or I don't know?
Yeah. So first, I think cannabis-based medicine is not something students learn about at medical schools and at universities. And when you do not learn about cannabis-based medicine at your university, then you have the feeling, okay, I've learned everything that is important for my work, but when I have never heard about cannabis-based medicine, then this is not that important, and it's more or less something that is used only by some crazy people. So this is the first aspect. When you do not learn about this during your education, later on you will definitely hesitate to use it in your clinical routine practice. And more specifically for psychiatrists, we treat patients who suffer from addiction. And this is how we learn normally about cannabis, because we see patients who are addicted from cannabis, who are diagnosed with cannabis use disorder. And this is in all heads of all psychiatrists worldwide. So they have this very close association between cannabis and addiction. And now you have to start to change people's mind about cannabis, because they learned when you use cannabis, you will be addicted, and you have to do all the best you can to stop use of cannabis. And now here you have to switch, and you have to learn, okay, there might be people, even patients who have an increased risk for addiction, for whom cannabis-based medicine might be effective and helpful. And you have to dare to use cannabinoids in patients where you know that they have an increased risk for addiction. So, for example, ADHD patients, it's well known that they have an increased risk for addiction. And
not only for cannabis, is it?
Yeah. For alcohol, other drugs. So this is well known. And this, of course, results in the situation that medical doctors are very skeptical about cannabis-based treatment in this specific indication, because they don't want to initiate cannabis use disorders in their patients. So this is a specific aspect we have to deal with in psychiatry.
But there may be also some hope, yes, because you told me that the acceptance of your research and your work has increased in the last years. So there may be some hope. Is it also a question of age? That older psychiatrists may think, the old school, they only associate cannabis with addiction, everything, and the younger may have heard already about other aspects. Or what can you give our audience a little bit of hope that also in psychiatry there will be a change? Or what's currently happening?
I definitely have this hope, because with time we will have more clinical experience. All medical doctors will meet patients who report about beneficial effects. So I work together with a lot of colleagues, and a lot of colleagues asked me to start this cannabis-based treatment, but they were willing to continue this kind of medication when I explained to them how to use it, and perhaps how to adapt the dosage. And when they learn from their patients that cannabis-based treatment may be effective and beneficial for the patients, then perhaps in the next patient they will decide, okay, now I can do it on my own and I don't need the help of someone else, and I can start this kind of medication. And the second is, I think we all do our very best to do some more research to have more robust data, and the more data we have, the more we will be able to convince people that cannabinoids are effective and safe in several different indications. But definitely, without data, we will not be able to convince the majority of colleagues. And this is how it works. So medicine is science, and science needs data. And without data, you cannot demonstrate that the treatment is effective. So there's no other way.
Very interesting. Okay.
But perhaps I can conclude with a sentence and my opinion that although I'm a researcher and I strongly argue for more well-designed clinical trials, until we have this data, we have to find a solution for our patients. Because when you have a patient who is really severely ill, and whether he knows or do not know whether cannabis-based medical treatment is effective for him, you have to find a solution how to treat him. And you cannot tell your patient, okay, come back in 10 years, then we may have robust data and I know whether this treatment is effective or not. So when you have a patient who already knows that cannabis is effective for him, you cannot offer any good alternative treatment, then I think it's ethically to decide to use cannabis even without having this robust data, because as a medical doctor, you have to help your patients, and the aim of treatment is to improve patients' quality of life. And when the patient says, okay, my quality of life is significantly improved, then this is the correct decision.
So this is a plea to listen to the patients, their experiences, and take them serious, and not giggling about it, but really to take it serious, and yeah. I see. Okay. Thank you very much, Kirsten, for this first cannabis talk. Very interesting. And to our audience, we are looking forward to the next cannabis talk. And Kirsten, I wish you good luck to find money for your research. We really need it. For Tourette syndrome, for ADHD and other psychiatric diseases, and also other diseases. And I'm very impressed about your continuous efforts to not give up, to do clinical research, even it is very difficult. It seems to be, you must have a very robust personality to keep on doing this work, even if you sometimes know I'm working for the paper basket or something like that. And but on the other side, it may also be rewarding that you really may change something, isn't it? Or where do you get your motivation? Is it?
Oh, this is a difficult question. So I really like my job because it's a mixture of clinical care for patients. I like to work clinically, and at the same time, I like to do research and to try to find out and to find answers for important clinical questions. And this mixture of these different aspects I like very much. So I learn from the patients and learn from patients what kind of research we should do next. And from the results from research, I try to give it back for benefit to the patient. So this is how I personally like to work.
Okay, very good. Thank you very much. Keep on your good work. And I hope to work with you together in the future again and again. And it's always a pleasure to work with you and to talk with you. And thank you again. Bye-bye.
Yes. Thank you so much for this kind conversation. And it was my pleasure.